So it's my pleasure to present you the results of a nationwide study from the French Association of Surgery, the Laparoscopic liver resection group, on the perioperative outcomes after laparoscopic liver resection in obese patients. As you know, obesity is defined according to the World Health Organization classification as a body mass index of 30 kilograms per square meters with 3 grades of severity depending on the body mass index. However, this definition failed to be adapted in the Asian population since the trigger points chosen in the Western population did not fit with an increased risk in this population. Therefore, depending on the population studied, the definition of obesity may vary, rendering the studies difficult to compare. We know that obesity and overweight are constantly rising over years, with 40% of the population being overweight, and actually 17% of the French population is affected with obesity. The issue is that obesity is a well-known risk factor of non-alcoholic fatty liver disease, also named as metabolic associated fatty liver disease, MAFLD, with different features varying from simple steatosis, NASH, to cirrhosis, and at last HCC. Obesity is also associated with an increased risk to develop primitive or secondary liver malignancies, among others, which participate to premature death. Laparoscopic liver resection is known to be feasible and safe with technical advantages that offer superiority to open approach on several points. In parallel, we know that the prevalence of MAFLD and metabolic syndrome, which are increased in obese population, are risk factors of postoperative morbidity after hepatic resections. To date, the impact of obesity failed to be firmly demonstrated in upper liver resections and after liver transplantation. Regarding the specific impact of obesity after laparoscopic liver resection, only few data are available with few studies of limited sample size and heterogeneous definitions of obesity, which does not allow to investigate the impact of other risk factors. Based on this data, we postulated the hypothesis that obesity could impact on the perioperative outcomes after LLR. To do so, we used the AFC LLR registry to conduct a study on more than 3,000 patients, 616 obese patients compared to 2,538 patients which were non-obese, with available anthropometric, postoperative, and tumoral type data. Our objectives were to describe first the LLR activity depending on obesity, then to compare the perioperative outcomes between obese and non-obese patients, and finally to investigate within the obese population the impact of non-risk factors of morbidity such as malignancies, cirrhosis, and older age. Regarding the LLR activity over a 20-year period depending on body mass index, we observed the widespread and growing use of LLR activity in obese and non-obese patients. However, the proportion of obese patients, 20%, remains stable over years, in spite of the growing obesity prevalence. Concerning the baseline characteristics, in comparison with non-obese patients, we observed that obese patients presented with older age, more comorbidities, more advanced liver disease with cirrhosis, and these patients underwent more frequently liver resection for malignant and primary tumors. Regarding the intraoperative outcomes between obese and non-obese patients, we observed that obese patients underwent more frequently major hepatectomy, with more blood loss, and a trend toward increased conversion rates. While global morbidity was higher in the obese population, 90-day severe morbidity according to the Clavier-Dindo classification, mortality as well as readmission rates were similar with non-obese patients. Then we compared the outcomes of obese patients operative of HCC, metastasis, and cholangiocarcinoma. We observed that in all indications, in spite of different baseline characteristics and management, intraoperative and postoperative outcomes were comparable. When looking at the impact of cirrhosis in obese patients, we showed that while cirrhotic obese patients had lesser major liver resections, 90-day mortality was 8 times higher with increased liver failure than in the non-cirrhotic obese group. Concerning the impact of older age, defined as an age above 65 years old, we found that while elderly obese patients presented with more comorbid conditions, 90-day morbidity and mortality were similar in spite of an increased length of stay and admissions in ICU. Finally, we investigated potential risk factors of 90-day severe morbidity in obese patients undergoing laparoscopic liver resection, and we found that preoperative portal vein embolizations, major blood loss, longer operative duration, and conversion to open approach were independently associated with worsened outcomes in the specific population of obese patients. Morbid obesity, meaning a body mass index above 40 kilograms per square meters, was identified in the univariate analysis, but did not match in the multivariate analysis. As a conclusion, we showed a widespread and constant use of LLR in obese patients over more than 20 years with similar safety regardless of body mass index. We found cirrhosis to negatively influence on postoperative mortality, while older age and resection for any malignancies had no influence on the postoperative outcomes. Finally, obese patients with preoperative portal vein embolization, intraoperative conversion to open approach, longer operative duration, and increased blood loss were those at higher risk of severe morbidity after LLR. Thank you.